This has been a very exciting discussion on targeted therapies. We want to switch gears and move on, talk about immune checkpoint inhibitors in lung cancer landscape as the next part. When immune checkpoint inhibitors entered the lung cancer arena, we were initially using them as monotherapy in the salvage setting. Then it moved to the frontline setting. In the last 2 years, we've been learning a lot about combining chemotherapy with immune checkpoint inhibition. At this ESMO Congress, we're learning more data about combining CTLA-4 antibody with the PD-1 antibody. So Johan, can you briefly talk about the rationale for combining a PD-L1 or a PD-1 inhibitor with a CTLA-4 inhibitor?
Yes, well, the rationale is that you tackle, if you give anti-CTLA-4 and anti-PD-1 or PD-L1, you tackle 2 points in the cancer immunity cycle, which makes it quite acceptable that you may have a more pronounced effect than with single agent immunotherapy alone. And so what we have seen here at this ESMO is another report of the CheckMate 227 study, because it's a never-ending story. It's a very complex trial with a lot of strata, with a lot of endpoints. But I think what we have seen here at ESMO is perhaps the most important presentation until now from CheckMate 227. Because we previously learned that the progression-free survival was better with nivolumab-ipilimumab than with chemotherapy if you give it in tumor mutation high patients, but this did not translate into overall survival data. So what we have here now is we have overall survival data, and we have overall survival data of the patients that do have PD-L1 expression. So they have at least 1% expression of PD-L1 on the tumor cells. And in that cohort that is reported now, the ones without PD-L1 expressions will be reported later, I suppose. There was a very important effect in the way that the combination of nivolumab and ipilimumab in terms of overall survival in that group did significantly better than the ones that were given doublet chemotherapy alone. And strange enough, this was the case both in patients with a high and a low tumor mutation burden. So this was now irrespective of tumor mutation burden. But what was of particular interest in this study, I think, is that the effect of superiority in terms of overall survival of nivolumab-ipilimumab versus chemotherapy was quite sustained. So in the overall survival curves, there was a plateau at 1 year and at 2 years where the nivo-ipi patients were clearly above the ones with chemotherapy. And this can be perhaps related to the fact that this is combination immunotherapy with anti-CTLA-4 and anti-PD-1, which means there may perhaps be more induction of memory cell effects, which could explain that the curves later onwards, and that's mainly what we want to see. We want to see plateaus with immunotherapy, and plateaus are clearly above the ones that we know historically. And I think this is the case in this part of the presentation of the CheckMate 227, so I feel it's a very important presentation.
And as you point out, Johan, the tail of the curve, elevating that, which means patients who are benefiting stay on that therapeutic benefit for a longer duration of time, is an important factor. And that's one of the key points in the CheckMate 227 trial, is the duration of response with immune checkpoint inhibition plus CTLA-4 combination, clearly much better than chemotherapy. Pasi, what are your thoughts on the durability of benefit with the combination of IPI and nivo?
Well, I think it's impressive. I don't think we see that with chemotherapy, even with maintenance chemotherapy. So I think it's a fundamentally different type of treatment approach, and I think it's gratifying to see that, and I think clearly opens up an option for patients to start with combination immunotherapy in the frontline setting as opposed to systemic combination chemotherapy. So I think it's an exciting finding, and really a welcome addition to our sort of immunotherapy armamentarium, especially in the frontline setting.